you, Dr. Turzo, and welcome to our podcast. It's great to have you.
Thank you. It's great to be here. I'm excited to be able to share.
Yeah, absolutely. So before we begin, just to kind of set the stage for everybody, what exactly is a DO and what is the practice of osteopathy?
It's a great question. And I can start by talking about what is an osteopathic physician in America, because it's different in America than in the rest of the world, actually. Osteopathy.
Really? Okay.
Yes. So we have different licensing capacities, basically, or regulations in America than we do in the rest of the world. So in the United States, there's two different ways to become a medical physician. There's two different organizations that regulate a medical license in the United States. One is the AMA, American Medical Association, and the other one is the AOA, American Osteopathic Association. And depending upon, and each one of those have different schools. So you have the allopathic, which is an MD medical school, which is 4 years, and you have the osteopathic medical school, which is also 4 years. So when you apply to medical school, you choose to apply to, you can choose to apply to both. And many do both. I was captivated by the osteopathic philosophy, and I was very clear I wanted to be an osteopath, and I chose not to apply to any MD schools. The osteopathic there's a philosophy behind how we practice medicine. My beloved husband's an MD, and we have a conversation often about this. There is no philosophy in allopathic medicine. It's basically kill all germs at all costs and avoid death. That's basically what they're, that's basically what underneath what they're trying to do is that. In the osteopathic philosophy, we have some basic principles, and that is that the body has the inherent capacity to heal itself. So we may put a Band-Aid on, but we're not healing the patient. We're creating an environment for the patient to heal itself. So it's really coming from a different perspective. So I do a lot of functional medicine also, and I come from the osteopathic functional medicine perspective, which is how do I help this person help themselves? Where are the obstacles of health? What is limiting this person from optimizing their own health? Another basic principle is that the body is a functional unit. So the body is one unit from the top of our heads to the bottom of our toes. There is no division, and there is no effect in one part of the body that doesn't have an effect in another part of the body. So if we have, and this really comes into play when we're talking about orthodontics, if we put braces on teeth and we move teeth, the whole head shifts, the base of the cranium shifts, the cervical shift, the posture shifts, everything shifts to accommodate those teeth coming together. And that's why it's crucially important to be able to have collaboration and to be able to work together and to make sure that when those pearly whites are coming back together, everything else is in alignment. Or else what do? We lock in a strain pattern. So coming back to the osteopathic principles, the body's a functional unit from head to toe, and structure and function are reciprocally interrelated, which means that a bridge is created in a certain structure to have a certain function, right? Just like our human body has a structure that has a function to it. So our structures function. That's really important. So we're coming from a more mechanical perspective of looking at the human body, meaning that if we have ribs that are not moving well and are restricted, if we get a pneumonia, most likely the pneumonia is going to go to the side where the ribs aren't moving really well.
Oh, got it.
So it's looking at the human body is not only a functional unit from head to toe, but that everything in the body has motion, and motion is health. And this expansion contraction that happens of the breath, let's say, in the body, that is also the driving force for arterial blood supply going to a cell and venous and lymphatic return going away. So I'm giving you kind of bullet points and trying to build a big picture of what the philosophy is of osteopathy, because that is a basic difference. The education is basically exactly the same as an MD, except for we have about 100 to 500 hours, depending upon what school you go to, what osteopathic school you go to, where we learn this philosophy, and we also learn how to diagnose neuromuscular skeletal issues. So we come out
of this is in addition. That 500 is in addition.
Exactly. So we have more class hours per se. And what happens with the MDs is they get out earlier and go to clinics and start doing more of their clinical rotations or clinical education earlier, a little earlier. Each school is
Okay.
very different. So we know how to work up back pain. When we graduate with our 4 years, we know how to work up a back pain or a headache or an ankle strain, and we learn 9 different ways of treating neuromusculoskeletal issues. But it's just like taking a basic course in cardiology. It's not enough to go into practice, but it's at least a something. And then once we finish our 4 years, then we intermesh together in our residency program. So like I did 1 year of a family practice residency with UCSF, which were almost all MDs. There was like one other DO. You know, in all residency programs, you'll find DOs and MDs in the same residency program. And I would say then you get licensed by your state, and our license is exactly the same. So if I had specialized in surgery, I would be doing surgery as a DO. But I didn't. I chose to, and then it gets complicated. And I'm so sorry about this, but it gets complicated.
That's okay.
Then 95% of my colleagues that are DOs don't practice the way I practice. So I practice as a traditional osteopath. In other words, I use my hands with every single patient to help them in terms of removing obstacles of health and helping their health optimize, basically. And I also do, I also did a 4-year training and taught in the world of homeopathy. I do PRP and prolotherapy injections. So I do cellular regeneration. I do a lot of the injections in the jaw joints because I work a lot with TMD. I see a lot of babies. I see children. So it's kind of like a family practice, old fashioned in a way, because I'm using primarily, I start with my hands to see what are restrictions in the body and what we can do to remove those. And in the rest of the world, the osteopaths are not medical physicians. So in Canada and Australia, New Zealand, France, they're more like chiropractors. So they learn they learn osteopathy, they learn the osteopathic portion and how to do the hands-on, and they learn how to use the 9 different modalities that are taught, but they're not medical physicians. So they can't do injections, or they can't prescribe medication. They can't do, they can't do anything that's in the world of a physician's world.
Interesting.
Yeah.
Very interesting. So when you say you're hands-on, it's and you touched on a little bit about modality. It's more how the body, if I were to come in and let's say I have, I know I'm having my annual sinus infection.
Okay.
So, let's just start with something like that. When you're hands-on, how do you move and see, you're looking not just to treat, hi, I have a sinus infection. You're looking deeper, is my understanding.
For sure. So inherent within principles of osteopathy is digging for etiology. And that's one thing that I think from my perspective, that's quite unique to osteopathy. So I'm trying to, if you came in to see me with sinus infection, which definitely is something right up my alley, I feel very comfortable with. I help many, many people with chronic allergies and get them off the antibiotics. I'm going to be thinking, what's going on? Where's their lack of motion? Why is there lack of motion in the mid-face? What's going on where we're not getting mid-face movement, and what's not happening that needs to drain your sinuses? So draining sinuses, draining the middle ears is an inherent capacity within a human body. And a lot of it has to do with the tongue, and getting the tongue up and back and getting the pressure change that happens through the mid-face when we have a functional swallow and a tongue resting position and a good dental occlusion. So if that's one of the things I'm going to look at. So I'm going to take a good history. I usually spend 2 hours with the patient initially. And that's where I'm going through absolutely everything from your birth history to your developmental history, to your nursing, sucking, swallow history, to your trauma history. What sort of head injuries did you have? Did you have any, babies fall all the time off beds, countertops? I go through that. Then I look at your orthodontic history, what else happened? Are your teeth actually in a physiological position or a non-physiological position because they were forced there and the rest of your body wasn't able to, and your rest of your body is now accommodating for this new dental occlusion that's man-made, that's based on classes like class 1, 2, and 3, which are lining up basically the first molar. But that's not a functional dental occlusion. A functional dental occlusion is when that dental occlusion is biocompatible with the rest of the body.
Gotcha.
Then I'm also going to be
Gotcha.
looking at your diet and your gut. So if I notice that I'm spending an hour and a half with the patient and they've got a great lip seal and they're breathing through their nose, now I'm like, why is it congested? Maybe it's from the gut, and maybe this person has a food allergy. So I do workup of the gut and I look at, maybe it's dairy, which a lot of times it is, or maybe it's wheat. And so then I'll see, like, how open is this person to changing their diet? That's very challenging for some people. So it's a very individuated approach. The non-individuated approaches give you antibiotics and just keep giving you antibiotics. And like, well, this is
every year, come back again.
This is your quote unquote genetics. This is the way it is. And I'm just going to keep giving you antibiotics. And this is like a, 5-minute appointment. No, thank you. Not going to do that. I want to find out why this person is having this chronic recurrent sinus infection. Something's not right.
Okay. All right. And you touched on this briefly, which they can't see. I was smiling when you did it.
Yeah.
But when you were talking about the occlusions and the man-made occlusions, and when I heard you speak at AAPMD, which I will put the link to that lecture in our show notes, one of the things you talked about was the impact of retractive orthodontics.
Yes.
And kind of the approach specifically around airways. That's one thing here at Children's Airway First that we have seen, and we're seeing over and over with people that we speak with other medical professionals. How do you approach, there's really no good way to ask that. I mean, how do you approach that? You have you have a patient that's coming in that they're having issues, and here they are, they're getting ready to either have orthodontic work done, in their teen years, or now you're in your 30s or 40s and you had that work done, and now you're presenting with chronic allergies, sleep apnea, things of that nature.
Yeah. Well, it begins with early intervention. So I'm all hyped up about children. I have children myself. Actually, they're now young adults, or they're trying to be young adults. We'll put it that way. Anyhow, I'm very passionate about children. And if I could probably retire now and feel fulfilled, because I know I've helped so many children. It's about, and now it's all about education. That's educating parents, educating my colleagues, educating the dental world, the malfunctional world about what are the signs that we see right when a baby's born that is going to tell us that this one is going to have an airway issue. So the airway issue typically comes before the teeth comes in. So the teeth come in, the teeth are coming in after the second swallow are already in place. And the second swallow have more to do with increasing oral volume than our teeth do. Our teeth are simply coming together so we can now have a couple of things. We can chew, and the chewing and the function of chewing and how we're chewing very much dictates the growth of the mandible. So this is epigenetics. This is how we use our function, how the functions in our face work is what develops a face. Learning how, yes, go ahead.
Oh, I'm sorry. So the airway issue most of the time is there at birth, or is it just
the signs of dysfunction that lead to airway issues?
Dysfunction.
Yes.
Okay.
Can be identified right at birth, and it really has to do with how they nurse, the second swallow of nursing, and it has to do with, can they nurse on both sides? Can they actually have the range of motion to turn their neck? If they don't, that's the subtle torticollis. So the birth experience is one of our biggest formative experiences that we have in our life that shape and form our head and our face, because our head is what's opening up the cervix. So the whole entire, how the baby's positioned, the kind of forces that are happening, the intervention that's happening from below up, let's say, have a huge effect on the functioning of our face and our head and our neck. So that's one thing that's being completely missed, is taking a really good birth history. The other thing is taking a really good trauma history. So there's portions of the cranium that don't ossify until we're 8 to 9 years old. So any falls on the back of the head can twist and compress different cranial bones, impinging on certain cranial nerves, creating entrapment. And this makes these nerves not function as well. And these nerves are cranial nerves 9, 10, 11, and 12. So 4 of these very important nerves that they all go to the head, face, mouth can be pinched and compromised with fascial strains. So the hands-on, if in my ideal utopia, every single newborn would have an osteopathic treatment from someone who specializes in cranial osteopathy. Every single, and if I can get them early enough, because I will go to the delivery room with my mamas that I treat when they're pregnant.
I was about to say
treat the baby at birth, but bring them to me a week later. I'm still happy. But those are ones, if I follow them all the way through, they don't need orthodontia. Because what we're doing is integrating the functions. So it's the functions that that go in the wrong direction, that create a structure that then is holding a maladaptive airway. So airway is simply a structure. I usually have a toilet paper roll with me, but it's a toilet paper roll. If you imagine a hole, a toilet paper roll, right? And you put that in the back of your tongue, that's your airway. And airway is collapsible soft tissue all the way around. So it's the function of those nerves to give the soft tissue tone to be able to increase the size of our airway. So it's not about pulling the face forward. It's not about rapid palate expanders, which only do 2-dimensional, not 3-dimensional expansion anyhow. It's about looking in the beginning at the functioning of these nerves to make sure that they're intact. And the action that expresses the intactness of these 4 cranial nerves is nursing. So if we're having to hold our baby like, over our shoulders, or can only nurse in bed on the right side, but not the left side, can only nurse laying down, these are all signs of compensations for a lack of tone and integration of these nerves and or a tongue tie. But not all not all nursing dysfunctions or nursing issues are tongue ties by any means. A lot of times it's low tone to the hypoglossal nerve, which is a nerve that innervates the tongue. So
can this be seen if you're not breastfeeding? Can you still spot it if the child is not breastfeeding?
Yes, you can assess the suck. So even if you put your little pinky in their mouth, I mean, if moms are doing it, it's hard unless you've had other children to compare it to. So you have to have a reference point of what's a good suck swallow. But if they have a low suck swallow and a low tone, then this is something that's worth looking at to see if it is a compression at the base of the cranium, which can quite easily be resolved. But if it's not resolved, the ongoing consequence leads to sleep apnea. Without a question.
Amazing. Okay. Wow. So another So another thing that I heard you talk about was about the food we eat.
Yes.
And I'm now, when I heard you do it, I have to be honest. I started retracing my steps. What did I feed my children growing up? I set them up to win. Oh my goodness. But you had mentioned that it actually impacts facial development and oral
100%. Yes.
How so?
Yes. So first of all, us moms, it's always our fault. We're always like, we've got this radar looking for where did we go wrong? The guilt one. It's just like, oh my gosh. Oh, God bless us all. Anyhow, yes. So what we eat forms our face. And the reason why is because it's not only nutrition in terms of the nutrient dense food that we need to build healthy bones and healthy muscles, but it is what we chew has an influence on how we chew. So if we're feeding our babies all these soft foods, the ones that are in the packages where you just like you're driving and you've got the kids screaming in the back and you just hand them the package and they squeeze it,
the
right?
Little applesauce,
the little applesauces, right? So those are all soft foods. So part of what's happened, if we look at evolution or the change of human faces over time, is that we have become more maxillary mandibular retrusive, which means that we're becoming more like bulldogs. We're getting a flatter face. And the reason for that is because of we're not chewing on bones anymore. We used to chew on bones for like 6 hours a day or something like that. Like there was a lot of chewing. We'd have meat that we'd have to work. Nuts, this sort of thing. We didn't have smoothies. We didn't have juicing, you know, we didn't have applesauce. So it's all these soft foods that are creating the experience where we're not using our jaw as much. And so there's many studies done on mice, rats. One of them, what they did was they took out the occlusion on one side. They took out how the bicuspid and the first molar contact on one side of the mouse or mice or rats, whatever, little poor rodents. And then they looked at mandibular development. And what they saw was that they had mandibular growth on the side where there was an occlusion, but on the side there wasn't an occlusion, the mandible didn't grow. So what it shows us is that with the amount of contact that happens, it's the contact and the compression that happens and stimulates bone growth. It stimulates the mandible to grow. So when I see the kids that are retrognathic, right? First of all, if I see a baby that's retrognathic, I know right away that mom has an airway issue. So what happened was mom
has an airway issue.
That's one of the main reasons why we're seeing all these babies with retrognathia, which means that the mandible's back. So what happens, I'll just jump onto that because that's kind of cool and interesting. So what happens is that mom has an airway issue and therefore the womb is a suboptimal oxygenated environment. And our environment is what dictates our growth patterns, right? Just like I'm talking about the epigenetics of what we eat creates a mandible. The same thing, the epigenetics happens in utero. So if mom has 4 bicuspid extraction, they've had braces, everything is pulled back, right? The tongue doesn't have room. So the tongue is gonna go back because the poor little tongue doesn't know where else to go. We have suboptimal oxygenation happening as we're developing our babies. And so the face of the baby is an expression of the environment it's been in.
Wow. That's a pretty big one for me. I just have to kind of let that one sit for a moment.
Yes, I understand that. It's coming from it's coming from a whole perspective and it's coming from a functional perspective, right? So much of our perspectives within dentistry is all structural. And we think of dentists as fixing cavities and making teeth align. So what this perspective is now we're going to look at, well, what brings teeth into their position in the first place? And it's not genetics. That is for sure. It is not genetics. It's not like when we have our kid that has not room for their teeth that we need to pull the teeth out because just so sorry, genetically, you know, your mom and your dad or, you know, whatever, whoever made you weren't compatible to create an oral volume that's conducive to life. So that is not true. What happens is it's the initial functions that don't go optimally that create a suboptimal structure. So our faces and the structure of our face tell a picture of how we've functioned with our nasal breathing, our lip seal, our tongue up posturing, and our chewing. Those are the main components that grow a face. So this is coming from the point of view of early intervention, is intervention on looking at the functions and trying to get those online so that we can develop a face that is perfect for us. It's a perfect expression of our optimal health.
And how early we can start is birth. How late can we make an impact with this approach?
Well, actually, we can do now pre-birth because now we can look at the moms and I can be like, you know what? How about if we do something to optimize your oxygen before you get pregnant? Right?
Wow.
Right? I mean, prenatals are nothing, right? Prenatals are nothing compared to like optimizing oxygenation. I mean, as human beings, we grow to oxygen just like a plant grows to sunshine. So we're going to contort and even in our structure as we're growing, you know, we're going to tongue thrust or we're going to lateral thrust with our tongue or we're going to open mouth breathe. We're going to do whatever we can to optimize that function in our body. And it's never too late to heal. If we're not dead, we're still transforming. That's my opinion. So,
I love that. Yeah. I love that. Now, this approach you're talking about, this is the ALF approach, correct?
Well, the ALF approach includes working collaboratively with an osteopathic physician, someone doing hands-on, a myofunctional therapist, and a dentist who's trained in how to adjust the ALF appliance, how to make the ALF appliance and how to adjust it. So it's very much of a collaborative approach, which I love, because I think that, my experience is that we can serve our patients that much better when we work together.
I understand that. Yeah, absolutely. And that's one of the things that we're at Children's Airway First rallying for, is this collaboration. I mean, we are much stronger together, and that includes everything from myofunctional therapy, DOs, MDs, dentists, everybody coming together. So with, looking at that collaborative approach, which would be, and at that point, treating the patient, the entire patient, from every aspect of the patient together. What stands in the way of getting the information that is needed? I'm going to try that again.
Yeah.
What stands in the way of obtaining the information that is needed to treat the whole patient, instead of this kind of siloed reactive approach, which is where at least American medicine is right now?
Well, it's a paradigm shift. It's really a paradigm shift. If the MD is fulcrumed within the germ theory and the, we're going to do medications, we're not going to dig for answers, we're not going to question, we're not going to be curious. And I mean, DOs can absolutely be like this too. I in no way mean to put it all on MDs in any way. Again, my beloved husband's an MD, so it's not about that. It's about that kind of approach, right? So curiosity. I think that actually I think there's a couple of things. One is curiosity. I think most health professions are not moving with curiosity. And to be curious, one has to take their ego and throw it out the window. Because you have to be, you can't be ego forward. And I call it ego forward. And that's just really not pleasant to work with, especially in a collaborative way. So everyone has to take their ego and kind of put it aside, eat some humble pie, recognize that, gosh, maybe I'm missing something. So that takes curiosity. Curiosity means an open mind. Einstein was very, very curious. He was a curious human being. Right, open-minded. And Buckminster Fuller was open-minded. That's where we can then integrate a new paradigm, is when we are open-minded, curious, questioning. And in order to do that, one has to have open eyes to look and see the problem in the first place. There's a lot of people that are just missing that there's an epidemic of airway issues now, right? And then there's a question of what to do about the airway issue. If you have the concept that the body is hard and rigid, because all of our anatomy that we're taught comes from dead people, and they're hard and rigid and they don't move. But that's actually not the living real experience of a human body. You can look at it from what a body looks like in surgery. I was fascinated with the human body, and I drove from LA to San Diego every day for a month to do autopsies all day long. And a lot of those autopsies were on children. And I was able to look at the inside of the calvarium, look at the dura membranes and how they actually feel, and look at the brain and look at the connection between the head and the cervicals. That was curious. And what I saw was, the human body that is basically alive or recently dead is very different than the anatomical perspective that we're having, that the body's hard and rigid. So if you have that perspective that the body is hard and rigid and is compartmentalized, then you can put in something that's hard and rigid and fixed in the upper palate and push the face forward. But if you come from the perspective that the body is a whole functioning unit, that anything that happens to the head is going to have consequences all the way down the body,
all the way down,
all the way down, then if you put something hard, fixed, and rigid in the body, it's actually not biocompatible. It's not biologically compatible with life, because living tissue isn't hard, fixed, and rigid. It's more of a biotensegrity. So this is where Buckminster Fuller gave us this phenomenal principle of tensegrity. The body has this capacity to have a biotensegrity, which means that all the pieces have to be moving, and the movement of each of the piece creates the stability in the body. So stability is created by the capacity for all the parts to move. So if you put something hard, fixed, and rigid, whether it's, a hard plate in the ankle or, in the hip, the rest of the body is going to have to compensate, which is fine. Sometimes that's what we have to do. We need hip replacements sometimes. But to know that there's compensations for it, and to be able to assess what are the compensations and to treat the compensations to optimize health.
Makes sense. Now, on the curiosity that you mentioned, which I have to say personally, I do agree with. Does that also require, though, the curiosity aspect of it, more time? You can't be this curious in 5 minutes seeing a patient. And you mentioned earlier, you spend 2 hours with patients.
Yeah, I spend 2 hours with the initial consult with the patient.
With the initial.
And my follow-ups are half an hour, which is still much longer than physicians are charging, basically. So it does put me outside the box. And one of the consequences of that is that I don't bill insurance directly. So it's all fee for service. And that has a consequence. And I have to deal with that consequence in different ways that I have to deal with it. So that was something I had to come to peace with when I was 26 years old and starting my practice, that I knew that how the gift that I had to provide wasn't going to be in the box, and there was going to be a consequence to that. One of the ways I feel like I can make up for it is teaching, spreading the word and talking about what other options are. And yes, you have to also, like, for example, we just had an orthodontist go through one of the courses that I teach at, and she sees 90 patients a day, and she couldn't fit the ALF approach into her practice at 90 patients a day because it takes more time. The ALF, right, which is a light wire that goes behind the upper and lower teeth, is every month you go in, you see the ALF dentist, they take it out, and they have to problem solve exactly where to activate the wire for that individual. So there's no cookie cutter. And so when you take cookie cutter, all the other ways, the palate expanders, BioBlock, orthotropics, DNA, homeoblock, all these things are turn screws. It doesn't take much intelligence to turn a screw, right? Doing the ALF approach takes time, and it takes education. So this is another issue that's happening is dentists are advertising, saying that they do the ALF, and it's really a catch and a bait and switch. I think it's called bait and switch, which they want people bait and switch. They want people to come in because they want more business, but they really don't know how to do the ALF. They haven't taken a course on how to do the ALF. And then they say, oh, the ALF won't help with that, but the BioBlock will, or orthotropics will, or this will help, or the rapid palate expander would be a better way for you. So one of the main questions from talking to parents is that if you go see someone who's advertising that they're doing the ALF, is to ask them what courses they've taken. And right now, the course that I can recommend wholeheartedly is the course with Dr. Bronson called the AEI, ALF Educational Institute. And that's something that I and teach with. So I help teach those courses to dentists. So maybe that's a rate limiting step, is for dentists to realize that if they're wanting to do this approach, they need to invest time and resources to get trained.
And do it the right way.
Do it the right way. Yeah,
absolutely.
It basically comes down to money and ego, I would say, right? It's being able to be like, well, I may not make as much money with this, but I'm at least doing no harm and I'm helping people. And the ego part, you have to throw it away if you want to be curious.
Right. Agreed. Absolutely agreed. So thinking about medical professionals, kind of shifting gears a little bit instead of parents from this perspective, what kind of questions should they be asking? Or are there questions they could ask to help identify some of these suboptimal airways in children earlier?
It's a really good question. The question that we have to start with is, who are they talking to? Are they talking to the dentist, or they're talking to the pediatrician? They're talking to the osteopath or the myofunctional therapist or the lactation consultant, so the answer, and then it was going to depend on if any of them have any education in this world of growth and development. It's basically facial growth and development of children.
Facial growth.
Right. It's airway is a consequence of the functioning of the face. So once again, we want to dig underneath, you know, again, imagine the toilet paper roll. It is literally a collapsible space behind the tongue. So we have to think of everything that affects that area of the body. And I have an on-demand course that's open for parents. Certainly parents, it's an on-demand course. It's 11 hours of me talking. And one of the lectures is called Airway and Beyond. And what I do is I take the airway, structure of the airway, and expand it into the function in the human body, which really comes down to breath and breathing. So breathing is a function and second swallow and chewing that creates an airway. So we want to again look at what are the functions. But to circle back around with your question, unfortunately, it's not a good. I don't have a good answer for it. I think it's better for parents to be educated. That's what I really encourage. There's you know, these podcasts. You can take my online class. Read the book. Read my book. All you have to do is read the book, and then the parents are going to be educated on what to look for in their children. And that way, we're directly advocating for our kids.
Got it. And by the way, I will put a link to both your book and the course, the on-demand course, in our show notes for parents. So just, you know, a couple more questions. When we're looking at this multidisciplinary approach to medicine, specifically around pediatrics, what does that look like to you? What is your kind of, I don't know, utopia? What is the right way to do it? What would be the end all be all for you?
So the form of it is what I actually have in my office, which, you know, pre-COVID, I had a myofunctional therapist come into my office every 2 weeks. Now she does everything on Zoom, but we're very collaborative in good communication. I have an ALF pediatric dentist in my office, and I have an osteopathic colleague in my office because I'm quite full. So I get to refer to someone who's been educated in all of this. That's kind of my utopia. I'm quite happy in that, and that can be created in other places in the world also. It's the connection with the osteopath who's trained in this. So it's very important for me to be clear. Many of my colleagues do not know about this. They don't understand the connection between the dental occlusion and the cranium. They don't understand, they don't even know how to assess tongue function. So that's what I'm very much passionately trying to do. I'm teaching so much, and I'm trying to get my colleagues to join in this, to really be able to stay on the cutting edge and to be able to give this service. It's not, circling back around to what does it look like, it's not essential. Like, it doesn't have to be that the ALF dentist is in the same office as the cranial osteopath or the myofunctional therapist. What's most important is that we have good communication and collaboration skills, you know, which is sometimes so personality dependent.
Working together.
So they can be personality limited. You know, if it's just someone on the team that you for whatever reason, you move in life differently than they move in life, and you don't feel like you can work together, even though you're both competent in what you do, it's going to be more challenging. So,
sure.
Yeah,
absolutely. What would you recommend to a parent that has a child that has a sleep issue, or is sure that their child has some kind of airway issue, whether or not they're at the stage of, okay, now it's braces time? How would you guide these parents? What would your recommendation be?
I wish I had a quick and simple one for that one, but it would depend upon the age of the child. Do they have teeth or not? How old are they? That gives me, do we have an option for an ALF or not? You know, am I dealing with, you know, a 1-year-old or a 6-month-old? So then I'm going to really look at their history, their birth history. I'm going to get my hands on them, and I'm going to see, you know, how the structure is moving. How's the base of the cranium moving? Is there good motion? I'm going to assess their interoral second swallow and look at that, look at their friend, you know, if they have a frenulum or something like that, and then start working with they're going to need either like, see someone to release a tongue, if that's really the issue. I work a lot with lasers. I love photobiomodulation. I think it's the absolutely cutting edge of medicine. I have a laser in my office where we use it underneath the tongue, and it can elongate the fibers. But so if some baby is kind of like maybe tongue-tied, maybe not tongue-tied, we treat them osteopathically, and then we use the laser to not just elongate the fibers underneath the tongue, but also to stimulate the neural integration of a second swallow. So we do points on the face. It's almost like, it could be, you could think of it as neural reflexive integration, but with laser.
Okay.
And it's phenomenal. So those are some of the what I look at in treating human beings that don't have teeth. It's interesting. Just this morning, I got an email from a family in Kauai that's reaching out that exactly has this. They have a 5-year-old. They haven't slept in 3 years. He has an airway issue, and they're like, "What do we do?" So the first thing I have to do is I've got to get online and assess the situation and like try to figure out what's going on with this specific human being. So finding someone who can help with finding out exactly what the problem is. Where's the obstacle? That's what we're trying to find. Where is the obstacle?
Right.
And then I try to connect them with an ALF. This one will go probably to an ALF dentist because he's 5, and if he's compliant enough, we can do 2, 3-year-olds. Yeah.
Awesome. So typically at the end of a podcast, I like to provide our guests an opportunity just to speak to parents and leave them with whatever you think is appropriate. So I'd like to offer you that time.
Oh gosh, that makes me almost want to cry. Oh, the first thing that comes up is that I'm just so sorry. It's just so challenging and so difficult to be a parent these days. 26 years ago when I was first in practice, the kids, it would be rare for me to see a kid with eczema and allergies and asthma and a breathing disorder. We didn't see that. It's only I've only been in practice 26 years. And now every single one of my kids, I would say, has a gut issue to some extent. They all have inflammation and gut issues. So all my kiddos I'm treating for gut issues. So I think I just have to say, hang in there. Whenever there's a problem, there's a solution. For glycophosphate, crazy stuff that's happening, it's like there's a solution to that. We just have to keep our eyes open and be curious and our ears open and be determined to figure out how to give our children the best care possible and to stay fulcrumed and function, right? It's easy to get overwhelmed. It's easy to feel like, just give me the magic pill. Give me the magic thing and make my kid either sleep or make this go away. Sometimes that happens, but don't compromise. Don't compromise for a quick fix necessarily that isn't long-term health giving, I would say.
Okay.
And I would put in that category things that are hard and fixed and in the mouth.
Got it. I cannot thank you enough for coming on here and sharing everything. It was absolutely educational and very enlightening. So thank you so much.
You're so welcome. I really appreciate the opportunity, and may all children be able to find their health.